Hello, future nurses. Welcome to your NCLEX-RN prep session. And today we'll sharpen your critical thinking and boost your confidence with an unfolding case study. So let's dive in and get one step closer to RN success.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Our first test type here is a hotspot or highlight. So the scenario says a nurse is caring for a 52-year-old male patient in the medical surgical unit with a diagnosis of alcohol abuse withdrawal and gastrointestinal bleeding. He has a history of chronic alcohol abuse, consuming a fifth, approximately 750 mL of vodka daily, with his last drink 2 days ago. On admission, blood alcohol level was undetectable. The patient was accompanied by his wife. Now, your task here is to highlight the assessment findings and lab results that require urgent intervention and follow-up. So let's go through the assessment findings and lab results. So around 7:45, we have the following results in the assessment, starting with the CIWA-Ar. It says the score is 10. Patient has moderate anxiety, restlessness, disorientation, and hand tremors. No hallucinations or seizures noted. And we have a note that says the severity of the CIWA-Ar. So for mild, the CIWA-Ar score is less than 10. Moderate CIWA-Ar score would range from 10 to 18. For severe, the score is equal to or greater than 19. Vital signs are the following: blood pressure of 135/90, heart rate of 98, respirations 20, temperature of 98.9 degrees Fahrenheit, and oxygen saturation of 95% on room air. Neurological assessment: disoriented to date, equal or less than 2 days, and plays exhibiting lethargy and restlessness. Cardiovascular assessment revealed heart rate regular, slightly tachycardic at 98 beats per minute. No murmurs or extra heart sounds noted. Peripheral pulses palpable. +2 bilaterally, mild pallor observed. Respirations even and unlabored. Respirations 20 cycles per minute. Lung sounds clear bilaterally. Oxygen saturation 95% on room air. No supplemental oxygen required. No urine output documented since 5 hours ago from the emergency department. No complaints of dysuria or urgency reported. Generalized weakness noted. Fine hand tremors bilaterally. Patient able to move all extremities, though slow to respond. IV fluids or IV access, we have D5, 0.9% sodium chloride with multivitamins infusing at 100 mL per hour via 20 gauge IV to left forearm. Site patent. No signs of infiltration or phlebitis. Gastrointestinal assessment. Patient is NPO, nasogastric tube in place to continuous low suction. Drained 100 mL of dark reddish drainage over the past 5 hours. Nasogastric tube patent, secured. No evidence of skin breakdown at insertion site. let's shift into the lab results. Hemoglobin of 9.2 grams per deciliter, hematocrit of 27.8%, red blood cells 3.1, white blood cells 8.5, platelets 180, mean corpuscular volume of 92, blood urea nitrogen of 28 milligrams per deciliter, creatinine 1.4 milligrams per deciliter, estimated glomerular filtration rate of 55 mL per minute, and sodium 135 milliequivalents per liter, potassium of 3.1, chloride 102, bicarbonate of 22, calcium of 8.5 milligrams per deciliter, magnesium of 1.4 milligrams per deciliter. So here I want you to carefully track and scan through each assessment finding and lab result. So you're not going to miss any of those urgent or assessment findings that will require urgent action. So the first finding that you should highlight here in the category is the CIWA-Ar score of 12. So what is CIWA-Ar? So this is a standardized tool that is used by healthcare providers, nurses. This is used to assess and monitor the severity of alcohol withdrawal symptoms, and this will also help guide us in treating the patient and the healthcare provider in deciding how much benzodiazepines to be administered for this client. So CIWA-Ar stands for Clinical Institute Withdrawal Assessment for Alcohol Revised. So this has been used for several years, has undergone so many revisions. Now, let's talk about the patient's result, which is 12. This falls in the moderate withdrawal range of 10 to 18. And this means this patient is not just at risk for the mild symptoms like anxiety or nausea. The patient is in a stage where serious complications like seizures or even delirium tremens can develop if this patient is not treated properly. And this score also determines how often we're going to check the patient, let's say every 2 hours, and how much lorazepam we're going to give him. And so, for example, a score of 12 means 1 milligram IV lorazepam is given as needed, and the threshold will jump to 2 milligrams if the score hits 19 or more. And of course, this will vary from one standard order from one institution to the next, but there's always that kind of standardization of the dosing here. And so this number directly drives our nursing action and the medication dosing. So this is a top priority that we should be monitoring. Now, the next assessment here that we should highlight is moderate anxiety, restlessness. So the anxiety is one of the symptoms that we need to assess with the CIWA-Ar tool. It's not just how the patient feels, but it's also a clinical indicator of how their withdrawal is progressing. And the moderate anxiety would usually score around 4 out of 7 on that section of the scale. And this reflects increasing autonomic nervous system activity, which happens when the body starts to react to the absence of alcohol. So this is not just emotional distress, but it is a physical symptom that plays a role in determining the CIWA-Ar score and the need for the benzodiazepines such as lorazepam. Now, the next word or phrase that we should highlight here is disorientation and hand tremor. So let's talk first about disorientation. So this, in the context of alcohol withdrawal, this is very concerning. It simply means the patient is confused. Maybe they don't know where they're at and what day it is, and that's not just a mental fog. So it can be a sign that their central nervous system is under stress. And with alcohol withdrawal, this can affect the gamma aminobutyric acid receptors, which help to regulate brain activity. And so when alcohol is suddenly removed or stopped, the brain becomes hyperexcitable, and this disorientation scored on the CIWA under the clouding of sensorium could be the beginning of more serious complications such as withdrawal delirium. Now, for the hand tremors, this is one of the early and classic signs of alcohol withdrawal, and also considered a very key symptom of autonomic hyperactivity, and this usually will begin about 6 to 12 hours after the last drink. And they're often fine, rapid tremors, and they're most noticeable in the hands and the fingers. Now let's shift into the next assessment. This is disoriented to date, equal to or less than 2 days, and place. So we are under neurological assessment here. So this just gives more detail about the patient's disorientation, and knowing that a patient is confused, not just in general, but specifically does not know the date or where they are, it tells us that there is cognitive impairment, and that is very significant. And so this should raise a red flag for you, and this reflects possible progression to the delirium tremens, which is also life-threatening. Now, in withdrawal management, this level of mental status change means the patient must be watched closely, and we're talking about neurological assessments and for the vital signs, so we can catch those deteriorations early on. Now, the next assessment finding here is lethargy. So this is a sign that the patient's level of alertness is reduced. So this is not just sleepiness. It can mean the brain is not getting what it needs, whether that's oxygen, or maybe glucose or circulation. And in this case, we know the patient has gastrointestinal bleeding and low hemoglobin, which means less oxygen is being carried to the brain. And they also have low potassium, low magnesium, both of which affect the brain and nerve function. And lethargy could be an early sign of worsening withdrawal, anemia related hypoxia, or even early hepatic encephalopathy in chronic alcohol users. So this makes it a finding that we should not ignore. Now, the next assessment that you should highlight is restlessness. So this might seem like a minor symptom, but in alcohol withdrawal, it can mean the body is going into overdrive. So this one reflects psychomotor agitation. Basically, the patient can't sit still. They feel jumpy or anxious. And that means their sympathetic nervous system is activated. And this is one of the things scored on the CIWA-Ar scale. And if left untreated, this agitation could escalate into severe withdrawal symptoms. So when you're going to pair this with a heart rate of 98 beats per minute, it may be a part of a bigger picture of withdrawal driven its autonomic instability. Now, the next assessment data that you should highlight here is no urine output documented since 5 hours ago. And so this is a serious finding here. No urine output in that amount of time suggests that the kidneys are not getting enough blood to filter. So the patient is likely hypovolemic from the gastrointestinal bleeding. We know they have 100 mLs of dark red nasogastric tube output, also low hemoglobin, and the kidneys are one of the first organs to suffer when the blood volume drops. And the labs support this too. We're going to go through that in a minute. So this is not just about dehydration. It could be early acute kidney injury, which needs immediate attention with fluids and careful monitoring. Now, what else do we need to highlight here? There's that fine hand tremors bilaterally. So understand that tremors are a classic hallmark of alcohol withdrawal, and they're one of the first symptoms we see as the nervous system becomes more excitable. And the CIWA-Ar tool scores tremors on a scale of 0 to 7. Now, in this case, the tremors were fine and bilateral, which confirms the nervous system is already affected. Also, the patient's magnesium is 1.4 milligrams per deciliter, which can make tremors worse and can also increase their risk of having a seizure. And so this is a symptom that not only adds to the CIWA score, but it also points to a possible need for magnesium replacement and seizure precautions. Now, what else do we need to highlight? We have drained 100 mLs of dark reddish drainage over the past 5 hours. So this one indicates active gastrointestinal bleeding, which is one of the primary diagnoses, or could be worsening. There's already a drop in the hemoglobin level. And so the urgent actions that you should do here would be to notify the medical provider for a possible need of maybe a transfusion if this worsens, and some follow-up of the laboratory. There's going to be serial labs output monitoring in order for us to check if the patient's GI bleeding is going to progress. And also we're going to monitor for the urine output and the complete blood count as well. Now, what else do we need to highlight here? There's that blood urea nitrogen of 28 milligrams per deciliter. So this is way above the normal range. And in this case, this points to a pre-renal cause. It means not enough blood flow to the kidneys. And this is often associated with volume loss. And so this will also fit with the gastrointestinal bleeding and lack of urine output. And so when the blood urea nitrogen is high and the creatinine is elevated, in this case 1.4, this supports the pre-renal diagnosis. And so this finding confirms that the kidneys are being affected, and this will help guide us in the resuscitation of fluids. Now, the next assessment or lab result is creatinine of 1.4. We know that this is a marker of kidney function, and this is slightly above normal for most adult males, even though not critical at this point, but this is a reflection that the kidneys is in an impaired state. And so when you're going to combine this to the anuria and the elevated blood urea nitrogen, it tells us the kidneys are definitely struggling. And this creatinine level confirms that the kidneys are not filtering properly. It's probably because of the poor perfusion from the blood loss, and also maybe dehydration. And if we're not going to address this, this could progress to full acute kidney injury. Now, the next assessment finding here, or lab result, is the estimated glomerular filtration rate of 55 mLs per minute. So this is a lab test, a way for us to assess the kidney function, and anything that is below 60 is considered mildly to moderately decreased. And for someone who was previously healthy, this drop suggests acute kidney injury. And since we already suspect the kidneys are underperfused due to the hypovolemia caused by the GI bleed and low blood pressure, this adds another piece of the puzzle, and this also reinforces the need for fluid management and renal monitoring. Now, what else do we have here? We have a potassium level of 3.1, hypokalemia, right? So this can cause muscle weakness. There's going to be arrhythmias. This can also worsen neurological symptoms. And in alcohol withdrawal, potassium is often depleted due to poor nutrition, maybe due to vomiting and stress responses. And we know that potassium is also essential for cardiac and muscular function. So we need to correct this as well. Now, the next lab value that you should pay attention to is the magnesium level of 1.4 milligrams per deciliter. And in reference to the range, it should be around 1.7 to 2.2 milligrams per deciliter. And so this is concerning because magnesium plays a big role in stabilizing the nervous system. And in alcohol withdrawal, the low magnesium can increase the risk of seizures and also can worsen the tremors and the agitation. And the magnesium itself can also affect the potassium regulation. And so if there is hypomagnesemia, there's potassium repletion and may not work well. And so this lab result has clear implications for treatment, and this patient will definitely need IV magnesium replacement as well, urgently. Now, let me filter through the rest of information here that you should not highlight. So one of those is the blood pressure of 135/90. So I want you to go back into the vital signs section. This is elevated, but this is not something that demands urgent intervention in this case. The patient is not in a hypertensive state or hypertensive crisis, I should say. And there's no evidence that this blood pressure is causing harm to this patient. So it might be elevated due to the withdrawal-related stress or anxiety, but it's not high enough to require as needed antihypertensive like labetalol, which is mostly reserved for high blood pressures like greater than 180 in the systolic. Now, we also have a heart rate of 98 beats per minute. It's near the upper end of the normal heart rate. It's still within the limit. So it may reflect early signs of hypovolemia or stress from withdrawal, but on its own, this heart rate does not signal a need for immediate action. And it's something to keep an eye on when you're addressing the more urgent concerns like fluid loss or maybe withdrawal symptoms or the electrolyte imbalances. Now, along with that, we have a respiratory rate of 20 cycles per minute and the temperature of 98.9, the saturation of 95%. All those fall within normal limits category. So let's jump into what else do we have here? Generalized weakness, that's under musculoskeletal. This is concerning, but not immediately life-threatening. It's a secondary symptom reflecting underlying urgent issues. Could be related to the anemia, hypovolemia, the deficiency of some electrolytes, which are already highlighted. So again, this is not an urgent assessment finding. Now, we have hemoglobin of 9.2 grams per deciliter. This is low, which confirms the client's anemia, likely due to the GI bleeding, but it's not low enough to trigger a blood transfusion per the standing orders, which requires transfusion, right? And so this is a relevant abnormality, but it is a stable one, and it doesn't require immediate right now. For hematocrit of 27.8%, this is also low. Also confirms the anemia, but this is expected in a patient with a GI bleeding, confirmed by the dark red nasogastric output. And this also mirrors the hemoglobin of 9.2. It supports the blood loss, but doesn't really meet the transfusion criteria, right? So we're going to park this. We also have the red blood cells of 3.1 million per microliter. This is also low red blood cell count. However, this is not really an urgent, or this is not an assessment finding that requires urgent action. And we need to keep an eye on this one though. Now, what else do we have? There's that white blood cell count of 8.5. This is within the normal range, and there's no indication of infection. So we're not going to be concerned too much about this. For the platelets of 180,000, this is within the normal range according to the reference value. We know that this is crucial for clotting, but again, there's no issue here. Now, the mean corpuscular volume, or the MCV, this is going to measure the average size of the red blood cells. And the normal range, according to the chart, it's around 80 to 100 FL here. And so this is only going to help us distinguish between chronic alcohol-related macrocytic anemia and blood loss-related anemia, but it doesn't change the treatment plan. Now, why is this not a priority? Well, it can provide a diagnostic clarity, but there's no immediate management implication here. And if you're going to compare it to the other manifestations or lab results, this is not requiring urgent action. Now, for the sodium level of 135, this falls in the normal range. This could be due to dilutional effects from the IV fluids or maybe the gastrointestinal losses, but it's not severe enough to cause symptoms like hyponatremia confusion caused by the hyponatremia or seizures. Now, this is also not a priority this time. Now, the chloride of 102 milliequivalents per liter, which falls in the normal range, we're not going to be too concerned about that. And the bicarbonate level of 22 milliequivalents per liter, this is in the normal low end of the normal range. So this kind of suggests some mild metabolic acidosis, maybe from the volume depletion or alcohol withdrawal. But again, this is not something that you should be worried about right now. The calcium, which is also 8.5, it falls within the normal range. And so something that you should watch for, but not really going to call for an urgent action this time. All right. Now, remember that with low calcium, this can coexist with the low magnesium, but the magnesium that we are seeing here has greater clinical consequences in alcohol withdrawal. As we are seeing the tremors, there's arrhythmias, there's possibility of seizure that can happen, right? And so it's not really a priority. It doesn't require correction right now. However, we're going to start replacing the calcium when it falls below 8.0 or whenever there's more symptoms like tetany. And again, this is not our focus this time. So I hope that you were able to capture all those assessment findings and lab values for you to pay attention. All right, let's move on to our next item. Actually, this is basically the CIWA-Ar scoring tool. So let me explain this briefly. And so the CIWA-Ar tool is a helpful screening tool that has 10 different symptom categories related to the alcohol withdrawal. And it's broken down into different parts. There's actually 10 segments. There's that section that says for nausea and vomiting, tremor, paroxysmal sweats, anxiety, agitation. There's tactile disturbances, auditory disturbances, visual disturbances, headaches, fullness, and lastly, we have orientation sensorium. So the 9 categories, okay, I'm talking about from nausea and vomiting up until headache and fullness. So the scoring here basically will be based on a scale from a 0 to 7. So this is going to give us a possible maximum score of 63 points across these 9 categories, right? So take a look here. The maximum score for each segment is 7. So again, if your patient probably has 7 each segment, then that's 63. But that's kind of impossible. I've never seen a person reaching 63. And the last segment about orientation and sensorium, this is going to be scored from 0 to 4. And so the total score here, the most possible total score will be around 67. But then again, it's not really, in reality, I don't think anybody has scored that much. Now, again, 67 is the most severe alcohol withdrawal symptoms across all domains, though, again, this is very rare in clinical practice. And so in the clinical scenario that we have, our patient has a score of 12. So according to that, we have a score of 0 for nausea and vomiting, 2 for tremors. We have 0 for paroxysmal sweats, and 4 for anxiety, and 4 for agitation, tactile disturbances 0, and auditory disturbances 0, visual disturbances 0, and headache, fullness 0 for now. And for the client's orientation sensorium, the nurse in the clinical scenario gave him a score of 2 for a total of 12. And so So this is just to give you an idea how the CIWA-Ar score is used in this patient. Now, let's move on into our next test item. This is the drag and drop close test type. So it says a student nurse assigned to care for this patient asked the primary nurse why the patient was manifesting the signs and symptoms of alcohol withdrawal. So your task is to complete the following statements to be made by the nurse by filling in the blanks with the correct term or phrase. So the paragraph says, chronic alcohol use acts as a blank altering brain function over time. It enhances blank, which calms neural activity while suppressing excitatory signals. When alcohol is suddenly stopped, the brain experiences blank due to reduced calming effects. This leads to symptoms such as blank observed in the patient's current state. The general priority in the patient's care is to blank given the alcohol withdrawal signs. Now let's look into the first blank here, and we got the following options. Central nervous system stimulant, peripheral nervous system depressant, central nervous system depressant, musculoskeletal system relaxant. What do you think would best fit here? So let's read into the statement again. Chronic alcohol use acts as a blank altering brain function over time. The answer here is central nervous system depressant. With the chronic alcohol use, as we have seen in the medical history, this acts as a central nervous system depressant, which means it's going to slow down the brain activity by enhancing the inhibitory pathways, and it will suppress excitatory ones. And over time, the brain will adjust by reducing its natural calming chemicals, and it will increase the excitatory responses to maintain balance. And this adaptation is why the brain becomes overly active when alcohol is suddenly stopped. And so this will lead to the withdrawal symptoms. Now let's look into the incorrect options here, such as central nervous system stimulant. Why is it incorrect? It's because stimulants will tend to increase brain activity. And alcohol does the exact opposite. It slows things down. Now, what about the peripheral nervous system depressant? Why is it incorrect? Well, this one deals with the nerves outside the brain and the spinal cord, and we know that alcohol's primary impact is on the central nervous system, particularly areas regulating the emotion, cognition, and motor function. Now, we also have musculoskeletal system relaxant. This is incorrect. We know that alcohol can cause some muscle relaxation, but it's not classified in this category pharmacologically. And its broader and more significant effect is on the brain and the spinal cord, not the muscles directly. Now let's go into our next blank here. It says it enhances blank. Our options are the following: dopamine, GABA or gamma aminobutyric acid, serotonin, acetylcholine. The answer here is GABA, gamma aminobutyric acid. So this, the alcohol can enhance the activity of the GABA, which is the brain's main inhibitory transmitter. And the GABA works like a natural sedative. It reduces the nerve excitability. It will calm the nervous system. But when the alcohol increases GABA's effect, it can result in relaxation, reduced anxiety, slowed reflexes, and even sleepiness. Now, we're talking about chronic exposure here, which will cause the brain to become dependent on alcohol to maintain normal inhibition. Now, we have the incorrect options such as the dopamine. What do you think about this one? Well, we know that alcohol does indirectly affect dopamine. It will create feelings of pleasure and reward, but it's not responsible for the calming effect that defines alcohol as a central nervous system depressant. Serotonin is also incorrect because this neurotransmitter regulates mood, appetite, and sleep, but its modulation is not what leads to sedation from alcohol. Acetylcholine is also incorrect. We know that this is important in muscle activation and memory, but this is not a major player in alcohol depressant effects. Now let's move on to our next statement. It says, when alcohol is suddenly stopped, the brain experiences blank due to reduced calming effects. So we have the options: autonomic hyperexcitability, hormonal suppression, motor inhibition, sensory dulling. The answer here is autonomic hyperactivity. And so when the alcohol is suddenly stopped, especially in someone who has used the drink heavily for a very long time, well, the brain can no longer balance its excitatory and inhibitory systems. And so with less GABA activity and a rebound in excitatory neurotransmitters like glutamate, then the result is autonomic hyperactivity. And this is going to include increased heart rate, there's going to be increased blood pressure, there's sweating, there's anxiety and restlessness. So the body's fight or flight system goes into an overdrive because it's no longer being suppressed. And so let's go into the incorrect options, and one of those is hormonal suppression. So this one refers to the endocrine changes, which are not the key drivers of withdrawal symptoms, while motor inhibition is something that would involve reduced movement, which contradicts the jitteriness and the restlessness of alcohol withdrawal. So this is also incorrect. And sensory dulling is also incorrect here, because alcohol intoxication might dull sensory input, but we're talking about withdrawal, which can heighten the input, sensory input, due to the central nervous system overactivity. Now let's head into the next blank here. And so the statement says this leads to symptoms such as blank observed in the patient's current state. So the following options are tremors, euphoria, hypotension, constipation. The correct answer here is tremors, and this is the hallmark early symptom of alcohol withdrawal, especially can be noticeable in the hands, and this can occur due to the sudden imbalance in the nervous system. Essentially, the brain is firing on all cylinders without alcohol's calming effect. And so, if untreated, the tremors can progress to seizures. It can also lead to delirium tremens, which is why we need to do frequent assessment for this patient. And so the rest of the options are incorrect, such as euphoria, because this one is associated with alcohol use, not withdrawal. And withdrawal is usually going to lead to dysphoria, which is an unpleasant emotional state. And hypotension is not really associated to withdrawal, because our patient will most likely going to experience hypertension due to increased sympathetic activity. And lastly, we have constipation. It's not a typical withdrawal symptom. And the patient around this time will tend to have gastrointestinal distress, but they're going to end up with nausea and vomiting, possibly diarrhea. And lastly, we have the statement, the general priority in the patient's care is to blank given the alcohol withdrawal signs. So the options are the following: correct electrolyte imbalances, optimize nutritional status, monitor cardiac rhythm stability, and prevent neurological escalation. The correct answer here is prevent neurological escalation, and this should be your priority for this client, to prevent neurological escalation. And so this simply means that you need to closely monitor the client for signs and symptoms, worsening symptoms, maybe seizures, hallucinations, or delirium tremens, and also to make sure that you're going to intervene early with administering the benzodiazepines such as lorazepam. And The goal here is to stabilize the patient's neurological status and also to prevent complications that could become life-threatening. So the rest of the options are incorrect, such as correct electrolyte imbalances. Even though this is a reasonable choice, and the patient's labs show hypokalemia, hypomagnesemia, which definitely raises red flags during alcohol withdrawal, and the low potassium can lead to heart rhythm problems, especially since the patient already has tachycardia, right? Or mild tachycardia. And the low magnesium can also make seizures more likely, which ties right into the neuro symptoms that we're watching out for. And since the doctor ordered potassium and chloride and also the magnesium sulfate in this case, it's clear that correcting these is also important. So yeah, it makes sense why this option would catch your attention. But why it's not the best answer here? Well, even though you're fixing the electrolytes with the administration of those replacement, it's not the top priority in this case, because the biggest danger right now is neurological escalation, such as seizures or delirium tremens, which can develop quickly, sometimes within a few hours, because of the brain's overactivity during the withdrawal. And so the potassium that we have, even though it's low, it's not dangerous low, like under 2.5 milliequivalents per liter. So the heart risk is not as immediate compared to 2.5. Again, this is something that we need to address, but if you compare the amount of severity or the severity here, we're going to prioritize neurological escalation. And of course, if we are going to administer magnesium, this is going to prevent seizures, but that's just one part of our action here. All right. And so, as we know that this patient is treated with benzodiazepines because they are under the CIWA-Ar protocol, they're going to get the benzodiazepines to manage those withdrawal symptoms head on. Now, the other options here, such as optimized nutritional status, we know that this is important for long-term recovery, but this is not the top priority during the initial withdrawal phase when the neurological symptoms dominate. And we have monitored cardiac rhythm stability. This is something that we need to also do, but if you compare it to the severity, we should not prioritize this one, because unless the patient has a known cardiac history, the neurologic risks such as seizures and delirium tremens take precedence in alcohol withdrawal care. So I did not say that we're not supposed to address all these, but again, if you're going to compare the need and the severity, we're going to prevent neurological escalation.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Let's move on our tour. Continuing to our next test item, we have a extended drag and drop. So the case here says the nurse reviews the patient's admission data and laboratory results after conducting the shift physical assessment. So your task is to assign 2 appropriate short-term goals for each nursing diagnosis. These are the diagnoses identified by the nurse: acute confusion, risk for injury, and deficient fluid volume. So we have the options for acute confusion. Patient will achieve full orientation to time, place, and person within 12 hours. Patient will report no new hallucinations or delusions during the next 24 hours. Patient will demonstrate improved memory recall for recent events within 24 hours. Patient will verbalize awareness of their current hospitalization and situation by day 2. Patient will participate in cognitive therapy sessions within 48 hours, and patient will exhibit reduced restlessness as evidenced by fewer bed alarm triggers. So what do you think would be the best or 2 appropriate short-term goals for this diagnosis? Now, for this acute confusion, you should be selecting patient will report no new hallucinations or delusions during the next 24 hours. So this goal addresses the acute confusion and hallucinations associated with the alcohol withdrawal, which are common symptoms, and monitoring and preventing the emergence of new hallucinations or delusions is also critical to manage acute confusion and to prevent the progression of delirium tremens. Now, the next short-term goal that you should select is patient will exhibit reduced restlessness as evidenced by fewer bed alarm triggers. And reducing restlessness is a key goal because agitation is a common symptom of alcohol withdrawal. And so with fewer bed alarm triggers, this indicate that the patient's confusion and agitation are lessening, which is a sign of improvement in their mental status and also a step forward towards managing acute confusion. And so the rest of the options here are incorrect. So if you selected patient will achieve full orientation to time, place, and person within 12 hours, this is unrealistic in an alcohol withdrawal patient, particularly during the active withdrawal phase when the confusion and disorientation are expected. And this goal should be long-term, as full orientation may not be possible in such a very short time frame. Now, the next incorrect option here is patient will demonstrate improved memory recall for recent events within 24 hours. And take note that memory recall is often impaired during acute alcohol withdrawal. And so expecting a patient to demonstrate improved memory recall in 24 hours may be unrealistic because it typically would be more feasible after the acute phase of withdrawal has been resolved. And the next option that is incorrect is patient will verbalize awareness of their current hospitalization and situation by day 2. We know that orientation or reorientation is important, but expecting the patient to verbalize awareness of their hospitalization within 2 days is also unrealistic because with the withdrawal phase, this is characterized by fluctuation of mental status and full awareness may take longer to develop. So again, another unrealistic short-term goal. Now, we also have patient will participate in cognitive therapy sessions within 48 hours. Do you think that this is appropriate? No, because cognitive therapy may not be effective in the acute alcohol withdrawal phase because the patient is likely too disoriented to participate meaningfully in such sessions, and reorientation and stabilization of the patient's mental status take precedence. Now, let's look into the next nursing diagnosis, risk for injury. So the 2 short-term goals that you should select here would be patient will remain free from seizure activity during the next 24 hours. So this is a priority goal because seizures are very common and also a dangerous complication of alcohol withdrawal. And so the goal of preventing the seizures in the first 24 hours is essential to ensure the patient's safety and also to avoid progression to delirium tremens. Now, the next short-term goal is Patient will show improvement in magnesium levels to greater than or equal to 1.8 milligrams per deciliter within 24 hours. Because we know that hypomagnesemia can increase the risk of seizures and alcohol withdrawal. And so if there's improvement of the magnesium, this is going to prevent the occurrence of those seizures or DTs. And we definitely need to monitor and correct this hypomagnesemia. Now, the rest of the options are also incorrect. So if you selected patient will demonstrate an understanding of seizure precautions within 8 hours, this is unrealistic to expect a patient who is in the active withdrawal phase to fully understand and verbalize seizure precautions. So the focus should be on immediate safety and seizure prevention rather than education at this point. Now, if you also selected patient will verbalize the importance of taking magnesium supplements daily, well, magnesium supplementation is critical in this case, but expecting the patient to verbalize its importance is unrealistic during the active alcohol withdrawal phase. So again, your goal should focus on improving the magnesium levels rather than patient education this time. Now, we also have patient will be able to identify symptoms of impending seizures by day 3. This is a goal that is not realistic. It's not feasible for a patient with an acute withdrawal because they are unlikely to be in that mental state that could allow them to recognize or identify those seizure symptoms. And preventing the seizures and stabilizing their neurological status takes precedence over patient education at this time. Now, if you selected patient will remain on seizure precautions until their CIWA-Ar score is equal or less than 10, well, this is also incorrect. We know that seizure precautions are necessary, but the CIWA-Ar score may not reliably predict when the seizures will occur. And so the patient should be monitored closely and should be treated with lorazepam and along with the magnesium supplementation rather than relying on the CIWA-Ar score alone. So we have to do the diligent nursing actions such as those replacing of the important electrolytes and making sure that we are administering the correct amount of lorazepam according to the score. Now, if you selected patient will have no history of seizure activity within 48 hours, what do you think about that? Well, this is incorrect because the patient must still experience seizures even with appropriate interventions during the first 24 or 48 hours. And the seizures can occur at any time during the withdrawal process. So it's more important to focus on immediate seizure preventions rather than expecting the complete absence of seizures. So keep that in mind. Now, the last nursing diagnosis that you should supplement here is deficient fluid volume. So the two short-term goals that you should select are the following. The first one is patient will maintain adequate urine output of equal or greater than 30 mL per hour. We know that a good or adequate urine output is a good indicator of fluid status. And in this patient who has been somewhat hypovolemic due to the GI bleeding, we need to monitor the urine output, which is very critical to ensure that there is fluid balance to maintain and that we are avoiding those kidney complications. Now, the next option here is patient will receive IV fluids such as 100 mLs per hour D5 0.9 sodium chloride and demonstrate improved hydration status. We know that this is the primary intervention for fluid volume deficit for this patient. And this prescribed rate will also ensure proper hydration, which is very critical for the patient's recovery from both alcohol withdrawal and gastrointestinal bleeding. And so the rest of the options are incorrect here, such as patient will consume at least 1,500 ml of oral fluids daily within 24 hours. This one is unrealistic because the patient may be too disoriented or nauseous to consume the oral fluids in sufficient quantity during the alcohol withdrawal phase. And what we should be doing here is to administer the IV fluids, which is more appropriate to maintain this patient's hydration at this time. Now, the rest of the options, again, such as patient will show normal blood pressure and heart rate within 12 hours. Although we are going to expect normalization, or we should be expecting normalization of vital signs. We know that that is important, but this is more of a kind of a long-term goal because the patient may still experience elevation of their heart rate and a blood pressure due to the ongoing alcohol symptoms or alcohol withdrawal symptoms, especially during the first 12 hours. So again, you gotta investigate each short-term goal if this is realistic or not. Now, the next option here, patient will experience no further GI bleeding within 24 hours. Although controlling the gastrointestinal bleeding is very important, it is not directly related to fluid volume deficit. We know that managing hydration and fluid balance is the priority. And the GI bleeding requires ongoing medical management as well. Now, we also have patient will demonstrate improved skin turgor and capillary refill time within 24 or 48 hours. We know that this is also useful indicator of hydration, but these changes may take more than 48 hours to normalize in a patient with fluid volume deficit and ongoing withdrawal symptoms. So definitely we need to monitor urine output, and we got to replace the patient's fluid via IV, which are all immediate priorities here. So I hope that you're able to capture all those short-term goals. Moving on to our next test type here. So this is a bow tie, and let's just review first the following documentation. The first section here is all about the healthcare provider orders that were entered around 6 o'clock in the morning. So let's go through the first set of orders here. It says D5 0.9% sodium chloride with multivitamins at 100 mL per hour. Maintain NPO status. Nasogastric tube to continuous low suction. Alcohol withdrawal management. We got routine dosing. Lorazepam 1 milligram IV every 6 hours for prevention of alcohol withdrawal symptoms. We also have PRN dosing per CIWA-Ar protocol. And so for CIWA-Ar score of 8 to 15, the order is to administer lorazepam 1 milligram IV PRN, may repeat every hour as needed. For CIWA-Ar score of greater than or equal to 16, administer lorazepam 2 milligrams IV PRN, may repeat every hour as needed, and notify provider for further evaluation. And the instructions include assess CIWA-Ar score every 2 hours or more frequently if withdrawal symptoms escalate. Monitor for sedation, respiratory depression, or hypotension post-administration, and document CIWA-Ar scores, response to medication, and any adverse effects. All right, so that's just first set of the orders. So let's move into the next one here. So the orders continue. It says check hemoglobin and hematocrit, or H&H, every 6 hours. Transfuse 1 unit of packed red blood cells. If hemoglobin is less than 8.5 grams per deciliter, transfuse 2 units of packed red blood cells. If hemoglobin is less than 7 grams per deciliter, vital signs every 4 hours as needed, based on CIWA-Ar score or clinical status. Monitor intake and output every 4 hours. Administer oxygen per protocol for oxygen saturation of less than 95 on room air. Labetalol PRN IV, first line antihypertensive. if the systolic blood pressure is greater than 180 or the diastolic blood pressure is greater than 120. And so the initial dose would be to give 20 milligrams IV push over 2 minutes. Repeat every 10 minutes, escalating as needed. So we have the doses of 20 milligrams, 40 milligrams, 80 milligrams, with a maximum cumulative dose of 300 milligrams. And that's for every 24 hours. So let's proceed here with the next information in the chart. So here's a brand new section of the nurse's notes. So around 8:50, the nurse documented reassessed patient with a CIWA-Ar score of 24. Symptoms include nausea, moderate bilateral hand tremors, beads of sweat on forehead, moderate anxiety, moderately fidgety and restless, reports very mild itching, pins and needles or numbness, mild visual sensitivity, mild headache, and disoriented to date by no more than 2 calendar days. Patient attempted to get out of bed 4 times, setting off bed alarm, rebinded to use call light for assistance. Vital signs: blood pressure 146/98, heart rate 106, respirations 22, temperature 99.2 degrees Fahrenheit, saturation of 94% on room air. Initiated oxygen at 2 liters per minute via nasal cannula to maintain saturation greater than 95%. Administered lorazepam 2 milligrams IV PRN as per protocol for CIWA-Ar score of greater or equal to 16. Notified healthcare provider of patient's current status and lab results. So the nurse notified the medical provider for the potassium level of 3.1, magnesium of 1.4. Received new orders: potassium chloride 40 ml equivalents IV to infuse over 4 hours for hypokalemia, magnesium sulfate 2 grams IV to infuse over 2 hours for hypomagnesemia, pantoprazole 40 milligrams IV every 12 hours for gastrointestinal bleeding management. Start continuous cardiac monitoring with telemetry and stat 12 lead ECG for every chest pain episode. So that's quite of a change in the client's condition here from compared to the assessment findings that we have seen around 7:45. And so this nurse's notes actually is detailing the different changes and the physician notification after all those abnormal assessment findings and lab results. So since this is a bow tie question, your task is to fill in the diagram by choosing from the options provided to identify the potential complication the patient may experience, 2 preventative nursing actions, and 2 parameters to monitor. So we have the potential complication options. We have Wernicke's encephalopathy, also delirium tremens. There is aspiration pneumonia, acute pancreatitis, and myocardial infarction. So what do you think would be the best answer for the potential complication? Well, that should be delirium tremens. So this is what we call as DTs. This is one of the most dangerous complications of alcohol withdrawal. This is potentially fatal if not treated. So this is something that you should expect, especially that this can show up about 48 hours to 96 hours after someone stops drinking alcohol, which perfectly matches this patient's timeline, right? So he's 2 days sober right now. Now, the big red flag here is that the CIWA-Ar score. Yeah. So the client score right now is 24 from a score of 12 about an hour ago. So this is already considered as a severe level of alcohol withdrawal, right? Previously, it was only 12. And so this is a fast and concerning elevation. So what we should be doing here is to look for things like tremors, anxiety, nausea, disorientation, And this patient checks many of the boxes here. There's nausea, there's moderate hand tremors, there's sweating, there's restlessness and anxiety, there's mild paresthesia, visual sensitivity. There's also disorientation. So all of these are classic setup for CNS hyperactivity, which is what makes DTs so dangerous. So let's not forget about the client's vital signs here. There's already tachycardia and the blood pressure is going up. Take a look into the blood pressure of 146/98. This is a big change from the previous blood pressure reading. And the respiratory rate also is starting to rise, 22 cycles per minute. And so the overall picture here for this client tells us that there is an ongoing autonomic nervous system overdrive, which is a hallmark of DTs. And on top of that, there is hypomagnesemia, there is hypokalemia. And because the electrolytes are low, this is going to make the seizure so at risk for this patient. There's also arrhythmias that can likely occur to this patient any hour, especially in this patient with alcohol withdrawal. So this patient has been given a dose of lorazepam 1 milligram, then 2 milligrams, and also magnesium sulfate to try and stop this from escalating. But it might not be enough. And the nurse stated in the notes that the bed alarm has gone off 4 times, right? So patient attempted to get out of bed 4 times, setting off bed alarm. So this is actually reflecting that the patient has increasing confusion and disorientation, and also tells us that this could turn into a full-blown DTs episode very soon. So when we're looking at all the possible complications, DTs really stands out as the most immediate, active, and life-threatening problem here that you should focus. Now, the rest of the options, such as the Wernicke's encephalopathy, this is incorrect because even though this is something that you should be concerned about chronic alcoholics, but this is something that is more associated with a loss of coordination. There's ataxia. There's going to be eye problems such as nystagmus or ophthalmoplegia. This patient is a little confused, yes, but the patient that we have in the case doesn't have other parts of the classic Wernicke's triad. There is no mention of unsteady gait or eye movement problems. And the client that we have here have anxiety, tremors, rising CIWA score that strongly suggest alcohol withdrawals, not Wernicke's. And also take note that the Wernicke's encephalopathy develops over a longer period. We're talking about days, even weeks, not hours. And so DTs would really fit here. Now, if you selected aspiration pneumonia, this is something that we always want to keep an eye on, especially if someone is nauseous or confused or has a feeding tube. But this patient has not vomited and his lungs are clear on assessment with oxygen improving with a low flow nasal cannula. That's good, right? So this patient, he's restless and a little out of it, so it's not really impossible, but there's no active respiratory distress here. There's no fever, no crackles. Now let's look into the acute pancreatitis. Why is this incorrect? Well, we know that this is something that can potentially happen, especially in heavy drinkers, but to suspect in this case, we'd want to see epigastric pain, maybe vomiting, maybe elevated enzymes like amylase or lipase, which we don't have. We don't see that in the labs, right? And so the patient does have nausea, but that can easily be from alcohol withdrawal, especially with a high CIWA-Ar score. And so this client's main concern seems to be bleeding via the nasogastric tube, not inflammation of the pancreas. Now let's talk about myocardial infarction. Why is this incorrect? Well, at the first glance, you might wonder about the heart rate. That is somewhat tachycardic, right? 106. The blood pressure is also elevated. The potassium is low. Could the patient be having a heart attack? Possibly. but there's no chest pain, no ECG, no troponin levels that would help us determine if the patient has a heart attack. There's no signs of ischemia. Plus, the vital signs are pretty common in alcohol withdrawal. So here, the sympathetic nervous system is activated, which can mimic the heart problems. And once we treat the withdrawal with the benzodiazepines, these should improve. So delirium tremens still takes the lead in the options. Now let's move on into the preventative nursing actions here. So what are these two? We have the options: administer lorazepam IV as prescribed, maintain a low stimulation environment. We also have apply sequential compression device, encourage ambulation every 2 hours, administer insulin sliding scale, administer ondansetron 4 milligrams IV. Well, remember that the patient is on the CIWA-Ar protocol. The answers are the following. The first one is administer lorazepam as prescribed. And this is according to the protocol. This is the gold standard for alcohol withdrawal. It will help calm the brain by boosting the gamma-aminobutyric acid, which is the main inhibitory neurotransmitter that the alcohol enhances when someone drinks. And when alcohol is suddenly removed, the CNS becomes hyperexcitable. This can lead to tremors, hallucinations, seizures, and DTs. And the patient's CIWA score right now is 24, which is very high. So according to the protocol, he's already received 1 milligram for a CIWA score of 12 from the previous hour, if you remember that. And then now, the patient is receiving 2 milligrams for a CIWA score of 24. So the nurse here should keep administering lorazepam as ordered, and also to reassess the CIWA frequently, ideally every 2 hours or even every hour. And the goal is to keep the symptoms under control and also to prevent the seizures, especially that the patient's magnesium is also low, and this can predispose him to one seizure episode. And so missing a dose or delaying could be fatal here, and this is a very high priority life-saving intervention. Now, the next action that you should select is maintain a low stimulation environment. Kind of seems very simple, but this is critical in the care of a patient undergoing alcohol withdrawal. We know that a quiet, low light environment can help reduce sensory overload, which is a big deal in withdrawal. The patient is already anxious, restless, visually sensitive, and confused. And so if there's too much noise, bright lights, or interruptions can actually push him over the edge into hallucinations or seizures. So what do we want for this patient in this case? We're going to do dim lighting. We're going to have to implement minimal staff interruptions. We're going to have to limit visitors, and we're going to maintain a calm, quiet room. And so if you're going to pair this with the administration of lorazepam IV, this is going to give the brain and the body the best chance to calm down. And so this is a key non-pharmacologic piece of DT's prevention. Now, the rest of the options here are incorrect, such as application of sequential compression device. We know that this is important to prevent DVT, especially if someone has been immobile for a while, but this patient hasn't been bedridden for a long time. He's actually trying to get up and triggering the bed alarms. And also, the DTs can set in within hours. So while the DVT takes days to develop, we know that SEDs don't do anything to stop the confusion. It doesn't stop the seizures. It doesn't stop autonomic hyperactivity. So it's not really a priority for this scenario. Okay? It does not address the core issue of alcohol withdrawal. So eliminate that one. Now, the next option here that you should eliminate is encourage ambulation every 2 hours. We're not supposed to do that. We know in a normal situation, in a normal patient, not on alcohol withdrawals, we're going to encourage ambulation. This will help circulation, lung function, and pressure injury prevention. But this patient is confused. He's restless and also a fall risk. So this patient has already tried to get out of bed 4 times. And if you're going to walk him around, this would be unsafe. This could trigger more agitation, which could worsen the withdrawal. And this will also precipitate the DTs. So in this case, you got to keep him safe and calm, which is more important than getting him up and have him walking. Now, the next option that is also incorrect is administer insulin sliding scale. Unless the patient has diabetes or high blood sugar, insulin is not going to help this case, right? What we need here is to administer the fluids. We're going to have to administer the lorazepam to keep the CIWA score down. We want to make sure that the patient is safe right now. All right. Now, what about administer ondansetron, 4 milligrams IV? We know that the patient now has a CIWA score of 24, right? This is a common withdrawal symptom. And ondansetron is a standard antiemetic medication that we often use for patients that may have nausea or vomiting. But this is not a preventive nursing action for delirium tremens. We want to include that preventive nursing action that will address delirium tremens. We're not talking about preventing the nausea in this case, so it doesn't really target of what we need this time. So you have to eliminate ondansetron. So don't get me wrong, this patient is probably going to be more nauseous or probably will be vomiting in the next few hours. But then again, our focus for the potential complication is delirium tremens. It's not about the nausea. So that's why it's not the best answer here. Now let's move forward to the parameter to monitor. What do you think would be the 2 answers here? Well, we have the options: level of consciousness, seizure activity, blood glucose level, peripheral edema, jugular vein distension, and cardiac rhythm. So the 2 parameters to monitor should be the following: level of consciousness. This is very critical for early detection of DTs, which presents as fluctuating mental status, possibility of hallucinations, disorientation, and potential progression to coma. And this patient already shows signs of disorientation and had prior lethargy, which suggests early central nervous system involvement. And the rapid increase in the CIWA-Ar score from 12 to 24 over an hour actually reflects escalation with much of a severity. And to add, the patient already received lorazepam 3 milligrams IV within an hour. Okay, 1 milligram at 7:50 in the morning, and then 2 milligrams at 8:50. So this can also increase the risk of oversedation, especially in a vulnerable central nervous system state. And so we definitely need to do frequent level of consciousness checks. We're going to have to use orientation questions or the Glasgow Coma Scale to help detect any worsening of the DTs. Also with a benzodiazepine that can induce sedation or respiratory depression. And also the possibility for the need for higher level of care, especially if there is going to be a need for airway support, if there is going to be respiratory compromise. This is a high priority given signs of both neurologic compromise and autonomic instability. Now, the next answer to this is seizure activity. We know that seizures are a classic and dangerous complications of alcohol withdrawal, usually occurring 6 to 48 hours after the last drink. And the patient's score for the CIWA score is 24. And the patient's heart rate is already going up. They're sweating. Moderate tremors are also red flags. And in addition to that, don't forget about the magnesium level of 1.4, which also lowers the seizure threshold. Though 2 grams magnesium sulfate was administered, but the risk still persists. The seizures can lead to status epilepticus. There's going to be respiratory arrest, on the possibility of progression to the full delirium tremens. And so the monitoring here should include watching the client for tonic-clonic movements or subtle twitching. We're going to maintain seizure precautions. We're going to pad the side rails, suction possibly, and also make sure that there is oxygen setup as needed. And we have to have those rescue benzodiazepines readily available according to the CIWA-Ar score. And so the rest of the options here are incorrect, such as the blood glucose level, because the patient has no history of diabetes or hypoglycemia or malnutrition. And the patient that we have in the case receives dextrose-containing IV fluids, which can stabilize the glucose, though hypoglycemia can occur in alcohol-related liver disease or starvation, but this patient's presentation is clearly withdrawal-related. It's not metabolic or glucose-related. And we also have the option here, peripheral edema. Edema indicates fluid overload, right? Or hypoalbuminemia, neither of which are present in this case. And in fact, the patient is likely hypovolemic due to the GI bleeding or possibly due to the poor oral intake. And this is evidenced by the lack of urine output for 5 hours. There's elevation of the BUN and creatinine. There is also decreased hemoglobin of 9.2. And here, we don't have any evidence of swelling, liver dysfunction. They're not confirmed. And so edema monitoring is more appropriate in long-term complications when the client may develop into liver cirrhosis, but not in this case. Jugular vein distension is also incorrect because JVD reflects right-sided heart failure or volume overload, which is not supported by this patient's data. And that's why we're going to eliminate this one. And lastly, we have cardiac rhythm. What do you think that we are going to eliminate this one? Even though the client has tachycardia right now, this is something that you're going to expect due to the autonomic hyperactivity, which is an expected withdrawal finding. And there's no arrhythmia, chest pain, or ischemia right now. And even though the patient has a hypokalemia of 3.1, but this is now being corrected with the IV potassium, and also the magnesium is also being corrected. And the delirium tremens primarily manifest with neurological deterioration, not primary cardiac rhythm changes. And so cardiac rhythm right now is not really gonna target to the delirium tremens this time. So I hope that you were able to capture the rationals.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Let's move on into our 5th test item here. So this is a matrix multiple response grouping. So let's take a look into the case. It says the nurse proceeded to organize her tasks after notifying the healthcare provider. Your task is to click the appropriate nursing interventions listed for each body system to address the patient's current needs. So we have body systems, neurologic, cardiovascular, renal, musculoskeletal, fluids and electrolytes, and gastrointestinal. So let's fill let's filter all the nursing interventions under each system. So what do you think about administer acetaminophen 650 milligrams PO, encourage ambulation every 2 hours, monitor for seizure activity, monitor for excessive sedation? What do you think would be the answers here? Well, this includes monitor for seizure activity, as we know that the client's recent CIWA-Ar score is 24. This increases seizure risk due to the glutamate-driven central nervous system excitability, which is also worsened by the hypomagnesemia. And so symptoms like moderate tremors, restlessness, and paresthesias that were observed around 8:50 in the morning actually signal potential pre-seizure activity. And so when you're monitoring for tonic-clonic movements, or maybe other subtle signs, maybe staring spells, will actually allow you for an urgent intervention here. You can administer the benzodiazepine as ordered. This will prevent status epilepticus or delirium tremens. And this is something that should also align with the recognition of cues in this test type. You're actually identifying tremors, the high score of the CIWA, and making sure that you are taking action. There's vigilant observation. Now, this is something that you should be doing, especially that the patient had his last drink 2 days ago. So around this time, the patient is at its peak to be on seizures. So you got to make sure that the patient is monitored closely here. Now, the other answer here is monitoring or monitor for excessive sedation, because we are going to administer doses upon doses of benzodiazepine here. This can cause respiratory depression, central nervous system depression. So what we need to watch for here are lethargy, slurring of the speech, slowed respirations, or maybe unarousable state. So we have to keep an eye into the patient's level of consciousness. And this action will also prevent oversedation related complications. This could include hypoxia, could be aspiration, which is very critical 2 days after the alcohol has been ingested and when the DTs peak. But sedation risk rises when we are administering the patient with so many doses of the benzodiazepine. All right, so don't forget about keeping an eye about the patient's respiratory function and neurological function. And so the rest of the options in neurologic system here, such as administering acetaminophen or encouraging an ambulation, they're not appropriate. Again, the patient isn't safe to walk around, the patient is disoriented, and they are at risk for falls, which can trigger more seizure episodes, right? And there's actually no need for us to administer the acetaminophen right now. Okay? It's intended to treat mild pain or possibly mild fever, but this patient is NPO due to the gastrointestinal bleeding, and the patient doesn't have any fever at the moment, so this doesn't really fit. Now let's move on into the next system, cardiovascular. What do you think are the options that you should select? We have the options: apply sequential compression devices, administer furosemide, 20 milligrams IV, initiate continuous telemetry monitoring, and monitor blood pressure every 1 to 4 hours as needed. So one of the correct options that you should implement this time is to initiate continuous telemetry monitoring. And this has been also, this was ordered by the medical provider once the nurse called him, right? So since the patient has electrolyte imbalances with the potassium and the magnesium levels being low, we have to capture those possible life-threatening arrhythmias, and we want to make sure that our patient will be monitored all throughout the duration while we are replacing them with those important electrolytes. Now, what else do we need to select here? There is blood pressure monitoring every 1 to 4 hours as needed, right? Our patient is already hypertensive, which is a sign of hyperexcitability, a sign of withdrawal. And so we really want to make sure that we are keeping an eye for this patient, because they can develop hypertensive crisis here if we are not addressing the CIWA scores. And the frequent checking of the blood pressure can also help track those elevations, so we can treat them with the use of the labetalol or maybe hydralazine or maybe the benzodiazepine to maintain a normal blood pressure here. Now, the rest of the actions here, such as application of the compression device and administration of furosemide, these two are not applicable because we know that SCDs, these are important, right? The sequential device is very important for preventing DVT, but the patient around this time is restless, getting out of bed several times. There's not really a known immobility, and what we should be watching for around this time is to capture those arrhythmias and the high blood pressures. And again, the application of the SCDs do not really address the withdrawal stress and the autonomic effects. And mind you, the SCDs can actually agitate the patient because these are like alternating squeezing onto the lower extremity. So this is not really going to be helpful for this patient around this time when they are confused. Now, if you're going to choose administer furosemide 20 milligrams IV, this is not intended because there's no signs of fluid overload. The patient is hypovolemic this time. The patient has no urine output for 5 hours. So this is not appropriate this time. This can worsen the patient's dehydration. Also, the electrolytes are already low. This can also cause hypokalemia, and it can also worsen the hypomagnesemia. Now let's move on to our renal system here. We have the options: encourage oral fluid intake, monitor intake and output every 4 hours, perform bedside bladder scan, administer erythropoietin injection. So the correct answers here are the following: monitor intake and output every 4 hours, because there's already some compromise. We have already seen that the BUN and creatinine are already elevated. There's elevation of the estimated glomerular filtration rate, which suggests renal hypoperfusion. And also monitoring the intake and output, especially the concern about the nasogastric tube drainage. This will also let us know about the fluid balance, if there is more gastrointestinal bleeding that can happen. So this intervention alone can recognize more cues. It also monitors the patient. It will detect any worsening of kidney function or any worsening of fluid status, right? Now, what else do we need to do here? We are going to perform bedside bladder scan. Why is this important? Now, take note that the patient has had no urine output for 5 hours, indicating anuria, maybe due to the hypovolemia or acute kidney injury, or possibly urinary retention. It's possibly from the withdrawal's neurologic effects. It could be caused by the lorazepam. It can decrease the bladder tone. And so when we are performing the bladder scan at the bedside, this is a non-invasive ultrasound that you can use, which will measure the volume of urine in the bladder, if there's any. And this is to distinguish if there is urinary retention or to distinguish if there is oliguria. And so if you have done this bladder scanning and if you detected that there is empty bladder, then this really is going to trigger you that the patient is probably in AKI, or acute kidney injury. So on the other hand, if there is going to be full bladder and they have not really urinated, then maybe the patient is now retaining urine due to the lorazepam. And so around this time, you're going to do all your attempts to make sure that the patient voids. And if unsuccessful, maybe there's a need for us to insert a temporary urinary catheter to drain the urine to prevent any urinary tract infection. Now, the other options here, such as encouraging oral fluid intake, is also inappropriate this time because the patient is NPO due to the GI bleeding, and also the patient here is at risk for aspiration due to the impaired level of consciousness. Patient is lethargic and confused, so they may not be able to follow your directions when you're allowing them to take a sip of water. And hypovolemia this time is much better addressed by administering the IV fluids, not oral fluids. So you got to be careful. Now, another option that is incorrect is administer erythropoietin injection. We know that erythropoietin can treat chronic anemia, but the patient's anemia around 9.2 is acute from gastrointestinal bleeding. So this patient doesn't really they're not really going to benefit about the erythropoietin here. It's not indicated for this client. Now let's move on into the musculoskeletal system. We have the following options. Ensure bed alarm remains active. Place a 1-to-1 sitter for close observation. Perform passive range of motion exercises. Administer calcium carbonate orally. What do you think would be best here? The answers are the following. Ensure bed alarm remains active because of the patient's severe disorientation and restlessness. And take note that the patient has already attempted 4 times to get out of bed. And also that the patient has received 3 milligrams of lorazepam in total. So this is going to increase the patient's fall risk. And this is going to increase their musculoskeletal injury. They could end up falling into the side of the bed, ending up with fractures or maybe sprains. So you got to make sure that the bed alarm is activated all the time. Now, what about placing 1-to-1 sitter for close observation? This is also a big deal, especially that the patient has repeatedly attempted to get out of bed 4 times. And due to the severe disorientation, the verbal reminders that the nurse is actually doing is quite ineffective already because of the patient's impaired judgment. They're not going to be compliant with the instruction. So placing this sitter to the patient's bedside would be the better option. This can provide continuous monitoring. It will prevent falls by redirecting the patient. Also can help the patient to address the cues, maybe if there's restlessness, disorientation. And also this can enhance safety. It sure will allow immediate response to unsafe movements. And it is more effective than passive measures alone compared to the bed alarm. So if you're going to do both, ensuring bed alarm and placing a 1-to-1 sitter, this would be a better combination. Now, the rest of the options, such as perform passive range of motion exercises and administer calcium carbonate orally. So let's break down each of this. Now, if you're going to do the ROM exercises here, well, this is important, right? For those patients that are immobile to prevent contractures. But this patient doesn't really fit into this kind of intervention here because the patient is agitated. This can further worsen their alcohol withdrawal symptoms. And this also ignores the cues. There's already mobility attempts. There's agitation. So this one fails prioritization. So eliminate this one. Now, if you selected administer calcium carbonate orally, this can help treat hypocalcemia or maybe heartburn, but the patient's calcium level is normal. Remember about the 8.5 milligrams per deciliter calcium value. And also the patient is placed NPO right now due to the GI bleeding. So this is inappropriate. All right. Let's move on into the fluids and electrolytes. What do you think would be the best answers here? We got restrict sodium intake to 2 grams per day, administer potassium chloride 40 milliequivalents IV 4 hours, over 4 hours, administer magnesium sulfate 2 grams IV over 2 hours, and infuse D5 water at 200 mL per hour. So the options here should be to administer potassium chloride 40 milliequivalents IV over 4 hours. So remember about the patient's potassium level of 3.1. It's going to place the client at risk for arrhythmias. So that's why there's that telemetry ordered. We need to continuously monitor the patient for any arrhythmias. Also, the patient is manifesting muscle weakness due to the hypokalemia, right? And so the potassium, according to this infusion rate, this will correct the hypokalemia. It will help the stabilize the heart rhythm, and also this will prevent complications such as ventricular tachycardia, which is essential in severe withdrawal. Now, the next intervention that you should select here is to administer magnesium sulfate, 2 grams IV over 2 hours. We know that the magnesium was also low, 1.4. This can increase the patient's seizure risk and arrhythmias. And the magnesium can also help correct this one. It will address the hand tremors as well. It will help the patient relax a little bit. So this also supports electrolyte stability. It will reduce the DT's risk, and it will also enhance the lorazepam's efficacy. Now, the rest of the options, such as restrict sodium intake to 2 grams per day, is something that is more applicable if there is fluid overload, or let's say hypertension related to hypernatremia. But then again, our patient here is NPO and also hypovolemic. There's no urine output for 5 hours. And so this is something that's not applicable this time. Okay, so the other option, which is infuse D5 water at 200 mL per hour. Remember that the client is already receiving the IV fluids, right? This will help address hypovolemia and also elevation of the BUN and the creatinine. And take note that the D5 or dextrose water, it lacks sodium. So this can increase the risk of hyponatremia. And the 200 mL per hour also exceeds the orders. It can potentially overload the patient, especially that the estimated GFR is already reduced. Remember about the 55 mL per minute? So there's already a compromise in the kidney function. So you got to be careful administering fluids for this patient. Now let's move on into our next system, gastrointestinal, with the following options. Administer pantoprazole 40 milligrams IV every 12 hours. Administer ondansetron 4 milligrams IV Q4 hours. Monitor nasogastric tube drainage for blood. Encourage a high fiber diet. So what are the answers here? Well, one of those is to administer pantoprazole 40 milligrams IV every 12 hours because our patient has active gastrointestinal bleeding. It requires acid suppression to prevent further mucosal damage. And remember, pantoprazole, this is classified as a proton pump inhibitor, which will reduce gastric acid. It's going to promote clot stability and healing. And this is also a critical intervention for gastrointestinal safety. It will minimize rebleeding risk, especially with a patient that is already nauseous. Patient score is 24, so we don't really want to worsen the client's condition. Another answer here is to monitor the nasogastric tube drainage for blood, since there's already bloody drainage coming out from the nasogastric tube. So we need to monitor for the volume the color, whether it's fresh blood versus coffee ground. And we also need to track the pH and also the bleeding status to make sure that we are monitoring for the pantoprazol's efficacy. Now, the rest of the options here, such as administer ondansetron 4 milligrams IV Q4 hours. So I want you to carefully sift through the statement here. Why is this incorrect? IV Q4 hours. We know that ondansetron is antiemetic, but it doesn't exist in the physician's order. This is intended to be given as needed, not routinely given every 4 hours. So this is inappropriate. Now, another option, encourage a high fiber diet. Our patient is currently NPO due to the active GI bleed. And so a high fiber diet this time can risk irritation or rebleeding, or it can exacerbate the gastrointestinal bleeding. So this is contraindicated around this time. All right. So I hope that you're able to capture all those correct answers and capture those distractors. Let's move on to our 6th test item here. So the case says the nurse is preparing to delegate tasks for the patient's care. For each task listed, determine whether it is appropriate or not appropriate to delegate to a nursing assistant or one-to-one sitter by checking the correct column. So we have different tasks involved here, and we have the 2 columns, appropriate, not appropriate. So I want you to scan through each action if this is appropriate to be delegated to a nursing assistant or a one-to-one sitter. So the first action here, or task, is assist with repositioning the patient every 2 hours. That's quite obvious, right? This is appropriate because this is a routine aspect of basic nursing care, also aimed at preventing pressure ulcers and maintaining skin integrity. This one does not require clinical judgment, and the nursing assistant and the sitter can safely carry out this task. What about the second one? Administer lorazepam 2 milligrams IV PRN for CIWA-Ar score. Obviously, not appropriate, right? Because this involves administration of medication, IV. This is something that is more appropriate to be done by an RN, okay? This is not within the scope of practice for a nursing assistant or a one-to-one sitter. This will involve assessment and evaluation of the patient's responses to the medication. Next, we have measure and record urine output from a urinal. What do you think about this? Yes, this is appropriate for a nursing assistant or a one-to-one sitter. This is a basic data gathering task that does not require nursing assessment or decision making. And accurate tracking of the fluid balance is essential in all patients undergoing alcohol withdrawal. And the nursing assistant here can safely contribute to this task by reporting the findings to the licensed nurse. Fourth, observe and report changes in patient behavior. Is it appropriate? Not appropriate. Well, of course, this is appropriate. Both nursing assistants and one-to-one sitters are expected to observe the patient continuously and to report any noticeable changes in the patient's behavior. Maybe increased agitation, increased restlessness or confusion, or maybe decreased level of consciousness. These are things that they can help by reporting to the registered nurse, right? Although they're not really responsible for interpreting the signs, but their reports are crucial for early detection of worsening withdrawal symptoms or maybe the onset of delirium tremens. Now, the next one here is perform a CIWA-Ar assessment. Obviously, this is not appropriate. This is only done by nurses and healthcare providers. And this requires the ability to interpret subjective and objective data. So that's why it's not supposed to be delegated to the NA and the 121 sitter. Let's move on to the next action here. Provide oral hygiene care. Yes, this is appropriate. This is a basic comfort measure that an NA can do. They can safely do this. They are trained to do this one. And providing oral care can also help maintain oral mucosal integrity. This can help decrease discomfort. It will promote overall hygiene without requiring any complex assessment. The next thing here is monitor nasogastric tube drainage for blood. The answer to this one is not appropriate, because monitoring for blood in the NG tube is a clinical task that involves interpreting the appearance and the volume of the gastric contents. And this is a critical responsibility that requires immediate nursing intervention. So do not delegate that to the NA and 121 sitter. Moving on to the next one, initiate raising the 4 side rails up. I want you to be careful. The answer here is not appropriate, because this is already considered as a form of restraint in many healthcare settings and must be used with caution. So the decision to use the full side rails requires nursing assessment, and in some cases it will require a provider's order. And the sitter and the nursing assistants are not authorized to initiate this action independently, because this will violate the patient's rights and the facility policies regarding restraint use. So don't do that. Now, assist with ambulation to the bedside commode with RN supervision. This is appropriate for the nursing assistant to help the patient to ambulate to the commode, especially when supervised by the registered nurse, simply because the patient is currently in withdrawal. They are at risk for falls due to the tremors, dizziness, and confusion. And so the supervised assistance will also support patient safety. This will promote mobility, while also ensuring that the nurse is present to intervene if necessary. So you got to be careful for this patient. Next is perform a bedside bladder scan. This is not appropriate to be delegated, because this one requires knowledge of anatomy, the operation of the machine, and the interpretation of the results. Even though some NAs may be trained to use the bladder scanner in specific facilities, but this is generally considered a technical task that falls under the nurse's responsibility. So there might be some inaccurate readings or misinterpretation that can happen here if you delegate this to the nursing assistant. So this might lead to inappropriate intervention. So it would be safer for the RN to perform this action on her own. And so this wraps up our Q&A today. If this session helped to boost your confidence, don't forget to hit like, click, subscribe, and share it with your friends who are also reviewing for the NCLEX. Stay focused and keep pushing forward. You got this. So I'll catch you on to the next review session. Thank you for watching.